Central neuromodulation for pain. So, what's central neuromodulation? When you define central neuromodulation, it's neuromodulation itself. That's changing the function of the brain. And I always say that functional neurosurgery is something different than structural neurosurgery. We change the function of the brain. So we are kind of intelligent neurosurgeons. Meditation is one. I put that first because I love that. Migraine patients, we tell them, we did a RCT, kind of RCT, told them to chant Om loudly 10 times and do 10 minutes of meditation. Another group, we just gave medications, and these patients were with medications also. And they had much, much better relief. And there are papers on it. There are papers on focus attention meditation changes functional networks in brain. When you look at brain as a target, historically, this is one of the old pictures. This was actually done in Marseille. These were French barber surgeons. Before the invention of stereotactic frame, they used to use this X-ray based things and put a frame on. And this was a patient who was treated for hemibody thalamic pain. Didn't survive, but do not try to cure the pain. Benefits are the same. So lower the risks. Know your patient. You got to know your patient. Type of pain. What type of pain is it? Neuropathic pain, nociceptive musculoskeletal pain, or visceral pain. Out of this, neuropathic pain is more likely to get better with interventions in brain or spine. Musculoskeletal, nociceptive pain, location pain on mobile parts. There are some special areas of pain. You have to look for sensory loss, allodynia, whether the pain is centralized and there is generalized allodynia or hyperalgesia. Neuropsychological issues. Neuropsychology is very ignored in our parts of the world, and even DBS patients sometimes don't get neuropsychology, movement disorder DBS patients. And just to give you a view of how my practice has evolved over all these years, and I just have numbers up to 2016, but lot of DBS motor cortex stimulations before. DBS has kind of remained constant, motor cortex has gone down, spinal cord stimulators have remained constant, PNS has gone up. So more invasive to less invasive. Similar benefits, less risk. To lesioning to DBS, MCS to PNS. So from DRACE to PALMS, transcranial magnetic stimulation, virtual reality I use a lot. Coming to cranial procedures as central neuromodulation, lesioning, DBS, and motor cortex stimulation. These are the three procedures that are the most important ones. We've done a lot of lesioning in past, and cingulotomies I still do quite a lot in cancer patients in cancer pain. And this is from old days. Now we use HIFU. HIFU is MR-guided focus ultrasound, and I was involved in Insight Tech, which is an Israeli company which developed this machine right from the development part. And one of my fellows, 𝐂𝐡𝐚𝐧𝐧𝐞𝐥, is one of their in charges. And we do this HIFU using tractography for movement disorders, but we also do it for for medial thalamotomies, for CL thalamotomies, and again works very well. Simple. This is a very simple procedure. HIFU. I mean, you go inside. That's a MRI scan, and that little thing there is something that goes on the head of the patients. There are ultrasound sources, 1000 to 1800, depending on what kind of machine you buy. And then there is water bath, because the ultrasound cannot go directly on a dry skin. It will burn the skin. Deep brain stimulation, and this is our first 10 patients of VC and CL DBS. I think we have a 20-year follow-up, and this is in publication. You draw a line from 10 centimeter long, ask them to mark, and then measure that. And that's a real visual analog scale, because when we say something, we try to round off things. So that's not an accurate score. And this was our targeting, and this is our leads, 2 leads on one side through the same burr hole. We used to use the same burr hole to put both the leads. And this is the mapping we used to do. And the last target, now PAG, PVG is also a very good target. You don't get much in the mapping, but again, you can get the feeling of warmth, and it kind of releases endogenous opioids. So this is also useful in musculoskeletal and somatic pain more than neuropathic pain. So, or this is useful as an adjuvant to VC and CLDBS. We have a pain patient with 6 leads in their brain. So I think 15 patients, nucleus accumbens DBS in chronic intractable pain, mostly post-thalamic pain. I think it was post-thalamic, post-stroke pain. And there was 30% improvement VAS, but daily activity score, SF36 and all those improved dramatically. So again, shows you affective component of pain goes away. You can function like a normal person even with pain. Wearable, this was Cephali, cranial wearable stimulator, and we also have our own cranial stimulator coming up. There are 2 electrodes right in the front here for supraorbital nerves, 2 electrodes for lateral branches of occipital nerve. When you get headache, you wear this, put this on, 15 minutes, headache goes away, take it out. Effect lasts 4 to 6 hours, like taking a medicine. So you keep on wearing it. And these kind of external wearable stimulators for patients with chronic migraine is much better than the pharmacotherapy. Causes side effects. So this is what we call nowadays is electroceuticals. We are out of era of pharmaceuticals. We are in the era of electroceuticals. So we can have electric devices for things which are chronic illnesses. TMS, transcranial magnetic stimulation. We have a neuronavigation guided transcranial magnetic stimulation, and we use it for chronic pain, depression, Parkinson's, lot of indications. For chronic pain, you stimulate M1. Again, same idea as motor cortex stimulation. Or you can simulate DLPFC, dorsolateral prefrontal cortex, if there is a large effective component. Direct current stimulation, TDCS, that also works. That's a variable stimulation. Spinal and peripheral stimulation. This was one of our patients where we did fMRI studies on spinal cord stimulation. So when the stimulator was on, not on right settings, with no pain relief, the only thing that it activated was S1 area. So could feel paresthesias, but no pain relief. Once started feeling pain relief, nucleus accumbens was the one that got deactivated strongly. There was not much in spinal S1 area, but nucleus accumbens, both sides, just got deactivated. Patient started getting pain relief. So that's a thing. That's what I'm saying. That peripheral stimulation also causes central neuromodulation. And this was our paper that came in Neuromodulation, where we actually deal bold images, fMRI images of different networks, resting state networks during spinal cord stimulation off with very high pain, and then with spinal cord stimulation on. And we could see the somatolimbic disconnection. This is one of our patients in ONS in fibromyalgia. Again, occipital nerve stimulation, but causes brain neuromodulation. So all the dorsal mode network gets activated, and all the medial forebrain gets deactivated. So central neuromodulation can be done by using variety of things, whether it's just shouting on someone, that will modulate, make you angry, or whether it's just touching someone, that will modulate your brain, make you happy or sad, depending on who is touching you. And peripheral stimulators, spinal cord stimulators, brain stimulators, everything can cause central neuromodulation. Thank you.